Karthikeyan, Dr. Jayasheela, then Dr. Mudami, Dr. Devendra, Sarup, all ready to get moving.
Okay, thank you very much. I'm going to share my screen in a second.
Yeah, because we have an inauguration ceremony. We have a small inauguration ceremony.
Okay.
I just a few minutes inauguration, then we are moving. Like that.
Actually, this is the first meeting Dr. Rajiv has organized for the IAP Emirates Neonatal chapter. So there is a brief inauguration, and the chief guest Dr. Mahmood is here.
We just finished the inauguration.
So 3 minutes. You can
3 minutes. Come. Ready? Are you ready?
Yeah.
Okay. Ready? Are you ready?
Yeah.
Good evening, everybody. Yes, Mike. Hello. Hello. Good evening, everybody. Don't worry about Mike. I think let's go. Okay, let's go. And today I'm very happy to announce that this long pending conference will take place. So basically delayed due to technical aspects and various other things which came up. So today I'm happy that we're able to go forward and get one of the best speakers available for us to learn from him today. But more importantly, I'm happy that all my colleagues from Dubai and from Latifa and the Dubai Hospital Medical Clinic all have joined me because they first thing they show their respect towards me and they feel that this event is important overall. So this I request Dr. Mahmood and Khalid and Mudit to light the lamp and from then inauguration speech by Dr. Mahmood. Please. Yes, please. Khalid and light the lamp. Khalid. Okay.
Good evening. It's my pleasure to be among my colleagues from the Indian Academy of Pediatric Emirates Neonatal chapter. And already Dr. Raj introduced the session. We are launching a series of lectures by experts from all over the world. And I will not speak too much because I think everybody is waiting to listen to the presentation by Professor Rakesh Sanai. So please welcome him, and he will be more than I hope. I'm sure we will hear very good information.
Good day to all of you. The fact I selected CPAP is because my long journey with CPAP for almost 30 years, and I did make an attempt to write a CPAP book maybe 10 years back, reviewed by Dr. Pauline. And I feel for all of us practicing neonatology, the end expiratory pressure management is the sheet anchor of management. Other things, the time volume, inspiry time, your volume guarantee, all are secondary to your perfect management of end expiratory pressure and FRC. How you recruit your FRC controls a huge amount of things. Today, when I thought that Rakesh would speak about the optimization of the end expiratory pressure and lung volume through CPAP, I think it's one of the most important things Rakesh is speaking today. And we're lucky to have a man doing 40 years of work at Columbia University to speak to us on CPAP. I think we have to learn and learn and learn about CPAP again before we proceed to any of the technologies applied today in neonatal practice. Thank you. Sridhar?
I'd like to thank all of you for coming and Dr. Rakesh for sparing the time. And, Dr. Rajiv has put in a lot of effort. It's a one-man show today. He has taken all the effort and all the success goes to him. Credit. And we are lucky to have someone who has taken so much effort to edit a book and publish it. It has taken 7 years according to him, more than 7 years. It's a hard labor and the results show for themselves. All of you have reviewed the book would find it useful. So I think Dr. Rajiv, please give a memento from on behalf of the AAP. Thank you for everybody. Thank you for your time.
Oh. Let's hope more stars come up.
So, as part of the question session at the end of the talk, I mean, it would be useful if all of you are in the group except Dr. Mahmood and Dr. Khalid, who of course are experts in the field. So, anyone who has questions, please message in the group and Dr. Rajiv can pass on. Dr. Rakesh, I hope you will have time in the end for questions also. Over to you.
At the end, we'll link and give again. We'll take. Yeah.
Let's start session. You can move this table up. Table up. Mike, please.
Can you all see my screen?
Yes.
Thanks a lot, Rajiv, for this invitation and this opportunity. Hello, everyone. I'm Rakesh Sani from Columbia University, New York. And this evening, your time, I'll be talking about the science and fine art of practicing bubble nasal CPAP. I have no financial relations to disclose or contact. The objectives of my talk are to discuss the rationale for the use of CPAP as an initial mode of respiratory support in preterm infants with respiratory distress. I'm going to talk about the desirable features and major components of the CPAP system and the benefits of bubble CPAP as a preferred method to deliver positive airway pressure.
Sorry, we can't see your slides at when you meant screen, I think. So
Can you just show us?
share this?
Sorry?
No, we can't see your screen in the sense the slides we can't see. We have to project it.
You can't?
No. Yes. Sir,
You can't?
no, we cannot see the screen. We are seeing your face.
Oh, just 1 second.
Yeah.
Let me.
There may be an option to share the
No.
screen.
Yeah, he should share. He
I
will get
thought I did. Screen one.
Enable to accept. Yeah, now it's fine. Now it's fine.
Yeah.
Thank you. Please go ahead. It's fine.
Please go ahead.
Okay. So I give me.
Yeah. We can go forward, Rakesh. Please go forward. You can
Give me 1 second. Right, so I've gotten locked. Give me 1 second, please. Okay. I think business. Somehow it's frozen on my monitor. Just okay, now. So you can see it, right?
We can see it, we can see it.
Okay. Ah, I have to.
He's not able to see this.
He is not able to see.
You put the camera facing that, so this computer can
Sorry for the problem. Just logging back in again. I don't know what happened here.
see. Can you see our screen? Then you can see your slides.
Keep this.
Okay, we're back in business. Sorry for that. Okay, and as I was saying, I'm going to talk about the desirable features and the major components of the CPAP system, and I'll also share with you the practical aspects of nasal CPAP application and strategies for its success. In preemies, better care also means hard choices. And this is highlighted by this nice New York Times article from 2012 that talks about the complete reversal. In 1960s, when the first NICUs opened, premature infants had 95% chance of dying. Look at today, they have 95% chance of survival. These gains are due to tremendous technological and biological advances seen in the past few decades. However, certain problems such as chronic lung disease or bronchopulmonary dysplasia persist. This is highlighted by the data published recently by Barbara Stoll and colleagues representing a prospective registry of over 34,000 infants ranging from 22 to 28 weeks gestation with birth weights of 401 to 1,500 grams and born at 26 of the NICHD network centers between the years 1993 and 2012. As you can see in their data, improving survival over 20-year period and an extremely low gestational ages of 23 to 24 and 25 weeks. If you look at the trends in care practices at these network centers over the same time period, the use of antenatal steroids has increased from 24 to 87%. The rate of delivery room intubation has decreased from 80% to 65%. And although the surfactant use has remained steady, the use of CPAP without needing ventilator has increased from 7% in 2002 to 11% in 2012. Despite these changes in practices at these major NICHD centers, the incidence of PPD defined as the need for supplemental oxygen at 36 weeks post-menstrual age continues to increase over time. Not only that, Patel and colleagues have recently reported the proportionate mortality for major causes of death according to the postnatal age, depending on the postnatal age. And you can clearly see bronchopulmonary dysplasia or BPD shown here in red accounts for more and more death with advancing postnatal age. So BPD remains a big issue and we need to figure out ways to tackle this problem. In recent years, several non-invasive respiratory support therapies and surfactant replacement techniques have been employed as strategies to reduce the incidence of BPD, and these have ranged from simple CPAP to BiPAP and non-synchronized and synchronized non-invasive positive pressure ventilation, also called as NIV-NAVA. Surfactant replacement strategies have also been modified with insured, minimally invasive and least invasive surfactant administration, and more recently, trials with aerosolized surfactant have also been performed. In addition, newer modalities such as nasal high-frequency oscillatory ventilation and hypronasal cannula are being utilized to reduce the incidence of PPD. For my talk, I'll be focusing on nasal CPAP as the non-invasive respiratory care modality. The use of CPAP or continuous positive pressure is not new. As early as 1971, Gregory utilized the CPAP delivered via an endotracheal tube in infants with idiopathic respiratory distress syndrome and demonstrated improved oxygenation in three different weight categories of infants. Then there was this landmark paper in 1987 from Mary Allen Avery and colleagues, where they addressed the issue of whether the chronic lung disease in low birth weight infants was preventable by reporting the incidence of PPD as defined as oxygen requirement at 28 days at 8 major academic centers in United States. Although the percentage of survival at 28 days was similar across all the centers, Center 3, shown here in red, that's Columbia University, had the lowest incidence of PPD. The authors reported unique care practices at this center. And what were these practices? Early institution of nasal CPAP in all weight groups with respiratory distress, acceptance of PCO2 up to 60 millimeters of mercury before intubation and mechanical ventilation, and preservation of spontaneous respiration without using any muscle relaxants. A few years later, Linda Van Marter and colleagues did a case cohort study to evaluate the relationship between NICU practices and occurrence of BPD in infants weighing 500 to 1500 grams at three major neonatal ICUs, Columbia, and two in Boston, Beth Israel Hospital and Brigham and Women's Hospital, and they defined oxygen needs at 36 weeks post-menstrual age. As you can see in the data, they reported a 5 to 6 times higher incidence of BPD in Boston NICUs compared to Columbia. And when they compared the care practices between the two groups, Columbia utilized higher CPAP, lower ventilation, and when they used ventilation, they used it for a shorter duration. The use of surfactant, indomethacin, and sedation was also lower at Columbia, and there were no significant differences in other morbidities such as IVH, PVL, NEC, or ROP. So, with that epidemiological background and some prospective data, I'd like to share with you some of the physiological effects of CPAP. So, what are the acute effects of CPAP on ventilation? It was nicely demonstrated by Zhang and colleagues, who showed that as the airway pressure increased from 0 to 6 centimeters, the end expiratory volume and tidal volume increased immediately and the breathing frequency decreased without affecting the minute ventilation. In the same animals, the authors showed that prolonged use of CPAP resulted in incremental increase in the total lung capacity. At 2 weeks, the lung capacity was 40% more than the baseline capacity. Further, this change in the lung capacity was due to increase in lung volume, lung weight, and the total amount of lung protein and DNA content. So it was not just distension of the lung, there was an overall growth of the lung. How about the effects of CPAP on lung recoil? So shown here are group deflation static pressure volume curves in excised air or saline filled lung in control animals and animals on CPAP for 2 weeks. Open circles and rectangles represent the air-filled lung, and the solid black circles and rectangles represent the saline filled lung. As you can see, there was no significant effect of CPAP on lung recoil in either air or saline filled lungs. So this preservation of volume corrected lung recoil in CPAP exposed animals suggests that this response does not involve a mere simple lung distension, but includes remodeling of the lung parenchyma. So this all makes sense, but is the use of CPAP as an initial treatment for preterm RDS evidence-based? This was a difficult question to ask in the past, but if you ask me today, the current clinical evidence, my answer is yes, yes, and yes. And why do I say that? If you look at the recent randomized controlled trials of CPAP for early respiratory support in preterm infants done over the past decade, they all support the use of CPAP. If you look at the Colin Morley's trial, POINT trial, which compared early CPAP with conventional early intubation, ventilation, and rescue surfactant, or the US support trial, which compared early CPAP with intubation, surfactant, and brief ventilation, followed by rapid extubation, the INSURE technique, or the one trial, which had 3 arms: CPAP arm, the conventional ventilation with intubation arm, with prophylactic surfactant, and the INSURE technique. The South American trial compared early CPAP with oxyhood with rescue surfactant in both groups if the oxygen requirement exceeded 35%. And lastly, the European trial, CPAP trial, which compared early CPAP with INSURE. If you summarize all the data and look at the primary outcome, which was the death of BPD, though not statistically significant, infants in the CPAP arm had a modest reduction in composite outcome of death or BPD across all trials, with a mean incidence of 29.2% in the CPAP arm and 33.5% in the intubation arm with surfactant. Importantly, there were no differences in the incidence of air leaks between the treatment arm, which was 5.7%, and intubation surfactant arm, which was 6.2%. So the question I may or why that's good. CPAP seems to be doing at least as good as intubation and surfactant. Why didn't we see that much effect of CPAP in these trials? And there are several potential reasons. I think most importantly,